This is Nursing Uncensored. Your host, Adrianne Benning, invites you to listen in on real conversations about all things in the nursing world. This podcast is intended for nurses, nursing students, and allied health professionals, but non-medical folk will probably get a kick out of us too. If you like what you hear, subscribe and share. Welcome to Nursing Uncensored. I am your host, Adrianne, and I am back again today with Craig of Keep It Real RN. Hi, Craig.
Hey, how are you doing?
I'm good. You're back again. We've got things to talk about.
Yes, we do. Well, this is the follow-up to the first episode
Yes.
where we talked about our poop nightmares, but this is the follow-up where we talk about actual techniques on how to deal with it.
As promised, we are back with some tips and tricks that you only pick up after kind of doing it for a while. Some of these things are, what do they say? Necessity is the mother of invention. So some of these tips and tricks we've kind of figured out on our own, and some of these have been passed on to us by the many wonderful nurses and patient care techs that we've worked with over the years. So we're going to kind of try to chop this into some, because there's a lot to cover here. So it's not going to be a comprehensive guide to every situation, but we are here to help you out for those poops wherein you have to stop for a second, use your nursing process to assess how the hell you're going to approach this, and then leave your patient clean and safe and hopefully not too terribly uncomfortable from the process of cleaning them up. So we're going to kind of break this down into a few different categories. Craig, what did we say? We've got some technique tips, talking about some products and supplies, and then maybe some final steps, kind of how to take care of things after you're all done cleaning the patient.
Okay, so when we attack this situation, the first thing that you do, like you were saying, you use your nursing judgment and you assess the situation. I mean, there are various elements to the situation. You have the quantity of stool to be dealt with, the quality of the stool, and the magnitude, meaning the magnitude. Is it just on the chucks? Is it all over the patient? Is it all over the bottom sheet and the top sheet and everything? Is it going to require a total bed change or a partial? So this is going to dictate the techniques that you use, the products that you use, and there are some things that we use that I'm going to share with you that just kind of give it that final sheen, as it were.
Yeah, because you want to leave your patient with a sparkling clean booty when all is said and done. You want to protect their skin, their dignity, and make sure that they're as clean as you would want to be. I think that's the golden rule. I think most nurses agree we all want a clean booty. So I think that the golden rule applies here. You've got to treat other people the way you want to be treated, and that includes pericare. So let's first talk about what you do when you walk into a room. Let's go through the Bristol stool scale here, okay?
I'm completely unfamiliar with the Bristol stool scale.
All right, so the Bristol stool scale, for those of you that don't know, is kind of a way that we classify how solid your poop is. Okay, I remember the day in nursing school, and I actually took some sneak photos because I couldn't resist. They actually gave us a PowerPoint presentation, a pooper point, if you will, wherein they kind of showed us photos of different types of stool. So the Bristol stool scale is a way to kind of quantify very easily if I'm giving a report, I say, I think, and I'm doing this from memory, so I don't have it perfect because I've got Epic, so I usually have a little chart in front of me, but I think it's on a scale of 1 to 7, 1 is hard little rabbit turds, and 7 is completely liquid with no solid. And then there are various steps in between. So like a 4 is like a perfectly formed stool, smooth like a snake, but solid. Like, I think that's what it actually says in Epic, like smooth like a sausage. That's what it says, smooth like a sausage. And so basically the Bristol stool scale is a way to kind of quantify the quality. So it's putting a numeric scale, because God knows nurses have to use a numeric scale for everything.
Oh, Epic loves numeric scales.
Numeric scales. But, you know, it does help, because if my perception, the way I describe something to you might not come across. Whereas if I'm giving a report, I can say they had a completely liquid stool, or I can say, they had a 7. However you want to communicate that, whatever the language of your unit is. But usually that's how we qualify. So if you've got somebody that has like a normal poop and they just happen to be incontinent, you might be able to get away with like just a chucks, change out the chucks, use maybe, a couple wet wipes to make sure they're clean, but it's no big deal and it's pretty easy. All the way down the spectrum, we have a situation where you walk in and you realize that your patient has had a completely liquid stool of a huge magnitude, like they haven't had a bowel movement or whatever for days, and suddenly the floodgates of hell have opened up, and it's from ankles to elbows. They've gotten their fingers in it. I've actually had a patient who once had it on their face. Like, I mean, it's like you leave them alone for a few minutes, they've pooped, and suddenly, if they're confused or for whatever reason they're not of their right mind, and then you're like, oh shit, I need pericare stuff, a full bed change, someone to help me, washcloth, you need a different set of skills for that kind. So that's why I wanted to kind of talk about the different levels of poop that we have here. So, Craig, what are some of the things that you're looking for when you go in and you want to assess what you need?
Well, the one thing that you look at is what surfaces are covered with stool. Is it just the patient and the chucks? Is it the patient, the chucks, the sheet? Is it the patient, the top sheet, the bottom sheet, the whole 9 yards, the SCDs, everything? It's going to dictate what you're going to need. It's also, the other thing you have to look at is what is the size of the patient too, and can they help? So that's going to dictate whether you're going to need to get some recruits. And that could be a whole nother topic in and of itself. It's recruiting people to help you with that, because nobody likes to clean up poop, and nobody really likes to help somebody else clean up poop. But it's one of those things that it always brings you good karma if you help somebody in their hour of need, because then you have somebody that you can call upon in your hour of need that will come up one day.
You've got to have that buddy on shift, that person that is going to step up in your hour of need when you have like a colossal poop to clean up. So I know that there are certain people that if I go to them and I ask them very nicely, and I maybe even offer to buy them a candy bar or some cheese balls from the cafeteria, then maybe they'll help me. Usually I'm prepared enough, though, that people have learned that I'm someone that you can clean poop with and not end up in a complete disaster situation. Because sometimes you end up in too deep and you realize that you don't have enough supplies for what you're there to do. And it's really hard to stop midway, especially if your patient, isn't able to like lay on their side for very long, or, you don't have somebody to run get stuff. It's all very complicated. So you really do want to start out with everything you need. So like if it's the whole bed, you go get all the linens, replacement, because you don't want to be in and out, because then you're also risking contaminating stuff by changing out your gloves 100 times and leaving the room. You want to get it all first go, So that's why, the magnitude is going to determine what you get.
Okay, so when you're recruiting somebody to help you clean up a colossal mess, one thing that's really appreciated, that I actually appreciate, is that when you ask me to come and help you, my time is valuable just like yours is. So when I come and help you, I'm taking time away from my patient load. So one thing I really appreciate is that you're ready to go when I come. Meaning you have your supplies ready, you have your wash basin and your water and your washcloths, and that you've cleaned up as much as you possibly can on your own. Meaning that, there's no reason you can't, clean up the top of the patient and do all of the top work prior to the arrival of your assistant. So what I like to do is, like, when I'm recruiting somebody to help me, I try to get as much as I possibly can done that does not require the other person helping to turn the patient. So once that person comes to help me turn the patient, that's all that needs to be finished. You turn them, you do the backside, you do the linen change, and they're out the door. And I'll make it pretty after that. I don't require that the person stay any longer than they absolutely need to.
Right. Like, once you've got the patient kind of back on clean linens, you do the pillow tucking, you get them their call light and set their table up and all of that. Yeah, like, just take your help for just the part that you actually need physical help with. That's super important, especially if you have patients that are pooping frequently and this becomes a situation where you're like recruiting multiple people multiple times over the course of a shift. Just make sure you've got everything you need. And that we also want to make sure, for the purpose of not wasting, we don't just want to take like a million supplies into a patient room. So really, you've got to judge. Is this patient stooling frequently? Should I have like a little supply of things on the table? Do I need, maybe you don't need to bring in some extra chucks, but I know if I have someone that like has diarrhea and they're incontinent and they're bedbound, I'm gonna maybe take in a few extra chucks when I go, because you never know how serious things are gonna get. So yeah, be prepared, have everything ready to go. I think a lot of supplies are pretty universally found in most hospitals. You've got, for really big messes, you've got your soap and water, basin, shit ton of washcloths. Just get a stack of washcloths sometimes. You said you've seen in hospitals, we had this ages ago, but you've seen the spray bottles. There's some etiquette, I think, that needs to be followed if you have if you work in a hospital that has bottles of Pericare spray. Do you have thoughts on this, Craig?
Yes, at my hospital, we still have that stuff. And again, it has its place. I mean, I could see it being used in the final sheen, but I see it being used, especially by the inexperienced people, as the primary weapon for combating this problem. And my experience with it is you spray that stuff on and you wipe it and the rag just continues to come out dirty. And it doesn't get anybody clean. And eventually the person using it just gives up after a while, and it just doesn't work. There is no substitute for good old-fashioned soap and water.
Absolutely. And, your patient's going to appreciate the time to get them actually clean, because as we all know, leaving that stuff on the skin is like acid. Like, that will get somebody, it'll start with like a reddened like dermatitis, like incontinence dermatitis, but then it can actually get to a point where that patient's ass is raw, and anytime you touch them, they like shoot through the roof in pain. So we're looking at the long game here. What's going to keep your patient clean and keep their skin in the best shape? So make sure you know what you have available to you and, where it is, especially if you're the new kid on the unit. Make sure you know where the washcloths are and the soap. And really, there are some tricks of the trade that vary depending on what you've got access to. I've seen folks that if they really have a huge stool to clean up and it's like all over their legs and their bottom and there's odor and it's hard to get their skin clean, I've even seen some folks put a little bit of like mouthwash in the bath water, just like a little bit of I don't know, whatever we've got, Listerine or whatever brand you've got in those little bottles. But sometimes that can like help cut through the odor and get them a little extra clean. But you have to be careful with that because you don't want to put something like that, you know, like menthol mouthwash on somebody's, you know, broken down skin. So what are some other techniques that you've seen used?
The first thing that you have to take into account when you're deciding what technique you're going to use is the magnitude of the situation. And it's like, how much stool are you really dealing with? Because the very first order of operations is always to debulk. You have to get down to the surface. And so if you have pasty poop, you have to use one technique to debulk it. If you have liquid poop, you have to use another technique to debulk it. And so that's the first order of operations. You have to debulk. So what are some of the techniques that you have used for debulking?
Oh, okay. So it's going to start, let's start at one end of the Bristol stool scale. Say you have like a lot of hard kind of, there's no other way to say it, little rabbit turds. You can honestly just take like a disposable wipe, pick that up, throw it in the trash, you know, roll it up in the chucks. But here's the thing. If you're using a cloth chucks and this is going to go into a hamper, which is going to go to a laundry room where another human has to handle it, don't just roll it all up in the chucks. Like whatever you can get into the trash, get into the trash. Okay. So whether that means using dry wipes to literally pick up turds and throw them away, or kind of like removing that, you know, I've been known, there have been times where like I've had enough liquid stool. It's not enough to set up suction in the whole 9 yards, like we talked about in the last episode where we basically wet dry vac that shit out. But sometimes I've, you know, used a graduate, like a little plastic measuring cup to kind of bail poop out of the bed. So it just depends on how big it is. And if it's a small liquid stool, I'll oftentimes just maybe use a graduate to scoop some of it up, get it into the trash, throw that graduate away as well, and then use dry wipes for the initial debulking, and then finish up with either soap and water, or we have really good peri wipes that, you know, we use to kind of finish up, and they have like a skin protectant in them as well. It kind of has a little bit of a lotiony texture to it. But I've been known to do all of the above. So I only use soap and water if it's like it's everywhere, hands, legs, butt, back, peri area. Like sometimes you end up with a situation where it's kind of everywhere. That's when I'll cut to the soap and water, and, you know, whatever other dry towels, you know, all that kind of goes along with basically a bath. Basically, you're giving them a bath if they've pooped that much. If it's a smaller amount of liquid stool, what I'll do, so one of the things that I wanted to touch base on is laying down a fresh surface. Okay, so this could mean a few things. When you have them rolled onto their side, you wipe up their backside, and then I take the chucks. If it's a disposable chucks, I fold it in half and kind of tuck it underneath them, so that what I've essentially done is I folded all the mess up into the chucks so that now nothing can get to it. It's pretty well contained, so I don't have to worry about dragging my arm through it or whatever. So that's the first thing. I've also sometimes taken like the dry paper. We call them fluffs because they're kind of fluffy and soft, but they're the dry wipes that we have. They're not absorbent in any way, but sometimes I will like take 2 or 3 of them, lay them down over the liquid stool so that, say, for example, the patient needs to lay back again because they need, you know, I work on a respiratory floor, so if people aren't breathing well, we might have to let them lay back again. Well, if I've just spent a few minutes cleaning them up, I don't want to lay them back into the poop that I just cleaned off of them. So if I know I need to lay them back for a minute before I continue, I actually will go ahead and, like I said, just lay down some dry wipes, create a new clean surface so that when they do lay back, you're not recontaminating. So those are some techniques that I use. I don't know if this is going to translate well in an explanation. I wish I could show people, but really you want to make sure that once you've cleaned up the poop, it stays cleaned up.
Right, because the last thing you want is for your new clean linen that you're going to be placing under this patient. You do not want to contaminate it.
That's why I don't fold up the dirty chucks until the butt is clean. So I do the butt clean first as much as I can, and then sometimes there's some on so far over on their cheek that you have to wait till you roll them to the other side to clean it. But I try to get as much off of their skin as I can, and then I fold up the dirty stuff and roll it up when I'm ready to tuck in the new stuff. Because here's the thing, if you've got somebody that is incontinent and they keep stooling, well, you don't want to lay down all of your clean sheets, and then while you're cleaning them up they stool again, and now you've just contaminated your clean sheets and you have to basically start over again. So I like to keep the dirty chucks ready to accept new donations until I am ready to put down the clean sheets and roll them over to the other side. So that's the first thing, is make sure that you're not exposing your new clean surface too soon. I think that sometimes that's the hardest part. Once you kind of contain the mess, then the cleanup is easy, because we all know how to wipe a butt. We wipe our own butts all the time. So that's not the hard part. But you do, like you said earlier, you have to take into account their gender as well, correct?
When it comes to men, you have one additional problem, especially when you have a man who has had liquid stool, and that their junk is usually swimming in said liquid stool. You need to assist Mr. Johnson up into some dry land in order to clean him, because otherwise, if he's sitting in this liquid stool, it is just a losing situation.
It's bad for everybody. I work with a lot of young female nurses, and so this can become an uncomfortable situation very quickly, especially if your patient is alert and oriented and yet still incontinent. So we all know that it can be hard, but really, as your patient's best advocate, you want to make sure that you clean everywhere, including under the scrotum. Make sure that area is especially clean, because think about how bad that would hurt to have raw balls. Nobody wants raw balls. This is the best thing that we can do for our patients, is protect that most delicate of areas. So you want to be gentle, of course, with any type of genital. If you have scrotum, you got to get in there. If you're dealing with a patient who has a vagina, then you need to make sure that there's nothing up in there. And it can be really difficult as a new nurse, or as a nurse who's not used to cleaning people up, to get into that area and really clean. And so I say to patients, I'm sorry, this is going to get up close and personal, but I just want to make sure you're really clean. Very few patients are going to stop you from cleaning them, as embarrassing as it is and as uncomfortable as it is for everybody. Patients want to be clean. Okay, unless they're really confused, in which case it is your responsibility to make sure that they are not making bad decisions for themselves, and that you actually are taking that time to get them really clean, even if they maybe don't want you to. But you gotta get into every fold, nook, cranny. Really, you want to make sure there's no area that's unclean. So yeah, sometimes you just got to be indelicate about it. You just got to say, I got to do this.
Right. When it comes to cleaning up Mr. Johnson, the one simple thing that you can do is you lift it up and you stick a chucks underneath it. And then that way, when you put it back down, it's not going back into the stool. And you clean and you clean and you clean. And you may even have to change that chucks, or actually put another one on top of it, until you get down to the nitty gritty.
Mm-hmm. And I know that if it's a poop that's kind of pasty or is difficult to remove from the skin, our tendency can be that we want to take that washcloth and we want to scrub it off. We want to scrub it off. But that also can be really bad for people's skin, especially if they've had incontinence issues for a while and they have raw or open skin. So you want to be mindful of what you're using and the force that you're using. I've seen nurses clean patients up and they don't warn the patient that they're about to touch them, and, they jump. There's that, like,
Right.
when somebody touches you in places you're not used to being touched by strangers, you
Right.
got to give warning. So I know that I worked in a feminist-based gynecology clinic for a long time, and before we would, like, go right in and, touch the genitals, we would maybe touch with the back of our hand on the inside of the thigh. Kind of like a warning, okay? So I'm not saying you need to, like, go through all these different techniques, but you just warn your patient that you're about to touch them. Make sure that you're using the amount of force necessary to get them clean, but not just being merciless and scrubbing, because that can hurt. You
Right,
wanna,
especially if things are already red and irritated.
yeah. And so, speaking to, getting the Johnson up out of the mess. I've even had patients where, if the fella has been stooling a lot and, you don't want their scrotum just sitting in stool. So I've even taken a pillowcase and I folded it long ways and used it like a hammock. Okay. So it goes over the top of the thighs, scoops under the scrotum to kind of lift it up, and then over the top of the other leg, so that what you're essentially doing is creating a hammock. So
Well, that's a fantastic idea. I've never even thought of that.
yeah, so that's something that I've seen done, and I've done it for certain patients. It's difficult if you have a patient that's really squirmy and is moving around a lot. It doesn't really stay in place. But if it's somebody who is mostly, able to kind of chill and not, move all over the bed, then this works really well.
Right. It kind of creates a little bit of a bridge for Mr.
It
Johnson.
does. It does.
He can look into the river and not be swimming in the river.
Exactly. And this also is really good if you have patients that have like scrotal edema, because then
Right.
you can kind of prop those puppies up and help, kind of promote the drainage of that swelling. So and so that's one of those things that on my unit, if I say like, hey, let's do let's do a hammock, they know, my nursing assistant or nurse that's helping me knows to grab a pillowcase, and then you just, you still have to replace the pillowcase, you still may have to do some cleaning, but at least you're not having the magnitude of cleaning. Most guys appreciate that. So I know that's a great pro tip. I hope that others will use that, because it can really save a person's skin.
Well, that's certainly one that I'm probably going to use.
Yeah. Another technique that I use, especially if it's someone that is stooling a lot, or they're hard to move, whether they be very large or they have wounds or broken bones. But I like to pre-make bedrolls. And you have told me before that you've not seen that technique used very often, but that you have seen it done, right? A bedroll.
Right. It's just not in my current facility. I don't even think that the majority of nurses who have never worked anywhere would even know what the hell I'm talking about.
Yeah. So I learned this while working on the burn unit at my facility. So on the burn unit, we have patients that have very extensive burns. We're a level 1 trauma center. And so sometimes you have patients that can only tolerate being moved for short periods of time. They're very goopy from all of the dressings and the slurries, which, the creams and the lotions and whatnot to keep their skin moist. And so when we're turning them, we want to be quick. We want to be like, get them on their side, tuck the sheets in, get out of there. So usually what most people do is they'll take like a sheet, and then they'll tuck, they'll put the corners on, tuck it in underneath them, and then take a chucks or a pull sheet or a draw sheet, whatever you call it in your facility. And then excuse me. And then you put down a chucks. You've got all these layers. And so sometimes when you're laying these down one layer at a time and trying to line everything up, it takes time, and that might be making your patient uncomfortable. If they're large, it means that your whoever's helping you has to help hold that weight for a longer period of time. So what I do is, we have a cot that we keep in the back hall of my unit. Up on the burn unit, they have a huge countertop that doesn't have anything on it. I find a surface that's, the size of a bed, so that what I'm rolling up isn't going to fall on the floor or drape on the ground. But I'll lay it out on the cart, and I'll lay out all my layers. So I'll lay down the sheet, well, not the fitted sheet, but if I'm using a flat sheet, then the draw sheet, then the chucks. Sometimes there's like a lift sheet if we're using like special ergonomic equipment with that patient, because we have some that we have slings that we can dedicate to a patient and kind of leave it under them. So every time we want to boost or turn, we can use. So anyway, there can be a lot of layers. Sometimes we have slip sheets that we can use for ergonomic purposes. I get that all in place, thinking about, okay, I always start from their hips. Where are their hips going to be? And I line everything up according to where I want it to fall on the bed. Take some practice to get used to lining it all up, but you learn through trial and error. Start the chucks kind of low, start everything kind of low, but then you roll everything up. And I roll it up really tight, like a scroll. So I roll it up going towards me halfway, and then I take, the sheet closest to me and I roll it up away from me halfway. And then I fold it in half, making sure I know which end goes at the head of the bed. And that way, because I've rolled it up like a scroll, I can, when the patient's on their side, regardless of what side of the bed I'm on, I can tuck in one half of the rolled sheet and then unroll the rest to lay on the bed. So it essentially takes all of the time that you would use to lay things down and line them up and tuck them under, and it just makes it one smooth motion. You move the patient, you clean them up, you tuck the sheet, you roll them back towards you. It saves so much time, and it's especially great if you have patients that are like hemodynamically unstable, they have respiratory issues and they can't lay flat for very long, or like I said, injuries, burns, wounds, whatever. That is that's my crowning glory. That's my number one tip that I could give people. It saves so much time and effort. It's unbelievable.
Yeah, I've used that technique before. I worked in a trauma unit way back in the day. And like you said, those patients too are people that wouldn't tolerate being turned for very long. So you better have things ready to go. And we used to do the bedroll thing, and that just saves a ton of time, and it saves a lot of misery for the patient too.
And it's so easy, to just, if I have downtime, I work nights, so, sometimes I have a bit more downtime than during the day, but if I know that the patient eventually is going to stool again, I just go ahead and I make that bedroll. If I have a free minute, and pretty much every time someone sees me do it, they go, oh my God, that's such a good idea. And so I want to spread that one around. So tell your friends, everybody, because that can really make a difference in the quality of the care that you're providing for your patient, making it easier on them and on you. And especially when we have very large bariatric patients, this is great because every second that you're expecting your coworkers or yourself to hold extra weight of that magnitude, to help that person lay on their side so that you can clean them up, you're risking injury. And so it's better to just be in and out as quickly as possible while still being safe. So that's pretty much my favorite one. Another tip that I try to tell everybody to do, and it all depends, I want everybody to know that all these tips and tricks, you still have to follow your hospital policy. So if anything that I'm telling you is against your hospital or facility's policy, that's on you. Don't do it. Know your policies. But something that I do is we have gloves we have good gloves. They're pretty thick. They can withstand a lot of friction. And so if I'm cleaning somebody up and I know it's going to be kind of a mess, I will sometimes triple glove. So I will put on 3 layers of gloves so that when I clean them up, so say I start to clean them up, well, sometimes in those initial minutes of cleaning up somebody's poop, you get it on your gloves. Like, it's inevitable. But what you don't want is then to get it on everything you touch. You don't want to get it all over clean things or recontaminate areas you've already cleaned. So I'll usually pull off that first layer once I've done kind of the big debulking and the big controlling. And then the second layer is to do kind of that final cleanup, whatever remains, because then my gloves don't get as dirty that time around. Then when I'm handling clean fabrics, I'm down to my 3rd layer of gloves. Because here's the thing. people say, well, just change your gloves in between each layer. Yeah, but then I have to take my gloves off entirely. My hands are probably sweaty. Then I have a hell of a time getting the gloves back on where they're actually fitting me properly, and it's a huge pain in the ass. So if I triple glove, I bypass that whole like, oh, now I'm trying to put, and then I don't have to step away from the patient. I don't have to fumble while people are waiting on me. So that's one thing that I do. I do the triple glove. Ever seen the triple glove done before?
No, I never have. That's going to be something that a takeaway that I think that I'm going to be using too, because like you said, it saves time. When you change your gloves, your hands are sweaty and it's hard to put on, and people are standing there waiting. And I can actually see that, just peeling off a layer is much quicker and much easier.
Here's the caveat. Sorry, I want to interrupt you. The one thing that you do have to be careful of with that is some gloves, similar to the same reason why you don't want to wear multiple condoms. Sometimes if you have latex or other materials, if you have too many, the friction can increase the risk of those breaking. So you just have to know if the gloves that you have are going to withstand that. If you have really flimsy, shitty gloves, maybe this isn't the best technique. So
very good. So now we've kind of covered debulking quite a bit. And the next step after that is actually getting that skin squeaky clean, because not only is it aesthetically appealing, but it's good for them too. Like you said, that, having stool on somebody's skin is very caustic, and over time it becomes red and irritated and broken down. So when it comes down to the final sheen, I guess that were, of getting that clean, I consider it not clean until the rag can go over the skin and the rag is still white. So one of the techniques that I have been told of, and that I use quite a bit when it comes to getting the final sheen on somebody, especially if they have skin where you keep wiping and wiping and wiping, and the rag is still kind of a brownish yellow every time you wipe, is to use some shaving cream on the washcloth, or you can even put it directly on the patient. But when you do that, what it does is it just takes that final fine layer of stool off of their skin. And I guarantee after about 2 or 3 wipes, your rag is going to come off of their skin clean. And not only does it come clean, but it also cuts the smell.
Mm-hmm. This is one that I haven't used before that I need to take away with me, because I feel like maybe I've heard people say this before, but I've never actually seen it done. So you're basically like you said, you're either squirting it right on their skin or like onto a rag, right? And then you're just using it. So then do you do a rinse once you...
Right. You have to get the shaving cream off of the patient. So it's going to take a few, clear rinses, as it were, to get it off. But once it's off, that final rinse that you're going to, that rag is going to come off squeaky clean. Now, the other thing that I have used, but it's not available where I work anymore. It used to be there. We used to have Johnson's baby shampoo in little bottles in our stock room. And that worked wonderful too, because that had a little bit of a fragrance to it and it would cut the smell. But apparently any of the soaps that have fragrance in them have been taken away because supposedly they're no good for a patient's skin.
Right. And also some, like we do chlorhexidine bathing on all of our patients, so that we're reducing their risk of infection and central line infections and whatnot. But some lotions, fragranced products, that sort of thing, if they're not approved by the hospital, they can actually counteract the effects of chlorhexidine. I didn't know this until I did a project with one of our nurse practice leaders at my institution. But yeah, so you want to be really careful about what products you're using. However, we're not using chlorhexidine on people's genitals and their backsides. And so as long as you're getting this all rinsed off and you're not just leaving it on their skin, I bet that does seem like it would be something that would work pretty well. Because our shaving cream is just your generic white, foamy, no fragrance, no menthol. So yeah, you got to know what's in it, but that's a great idea. Similar to how, if we're using soap and water, we'll put a little mouthwash in there to kind of cut through that grime. Because sometimes it's true. You wipe, and never. What did I say last episode? It's like wiping a magic marker.
Right.
that
exactly.
I think is a Chris Pratt quote from Parks and Recs. But yeah, it's true. And then it gets frustrating because then you feel like you're there forever. And especially if they have like, I've had family members that like a spouse or whatever is helping me because, we like to include families if they can safely do so. But then, not only do you owe it to the patient to get them clean, but then you've got this family member watching. And so you can't just be like, oh, whatever, it's good enough. Like you need to get that patient clean. So you need to sometimes step it up and use some of these other products. And I also want to say, if you work in an institution that has, like we a long time ago had the spray bottles where you literally, it's like a pump spray and that's the peri spray. The thing is, if you're going to spray somebody with that, you got to warn them because nothing feels worse than being sprayed kind of suddenly in the rectum with cold liquid. Like that's not comfortable. So if you are using spray it on the rag. The fluffs that we have, like I said earlier, they're not very absorbent. And so sometimes it's nice to wet those down a little bit because then they become a little softer and a little easier to work with. Use warm water. Please don't shock your patients with ice cold wash rags. Be a little bit merciful, okay? Lots of stuff in the hospital is cold, so let's warm up the things that we can.
Exactly. So now we've talked about debulking, we've talked about different techniques using for cleaning up. After you're all done, now we have to talk about that 1 ounce of prevention is worth many, many, many minutes of cure, as it were. So what are some of the techniques that you use to try to contain the next event?
Oh, I think the number one thing you can do is make sure, I wrote on my little note sheet, do you know where your chucks are? When you have any kind of protective sheeting underneath your patient, we call them chucks, whatever you call them at your facility, incontinence pads, drapes, whatever. Make sure that it's in the right place, because if you've boosted your patient 100 times and that chucks is no longer underneath their butt, it's not going to help you. It doesn't do any good behind their shoulders. So make sure that you always have your chucks low enough that it's going to prevent anything from, we talked about running down the channel, where if you have someone whose thighs are touching, which is most people, then if they, especially the women, if they pee, it kind of comes up and over the top and then runs down their leg. So sometimes you might even need an extra chucks. You might need to go to the foot of the bed with the chucks. I know that we have done kind of a diamond technique where we use disposable chucks. Patients that are incontinent or incontinent of large amounts, we'll kind of put one of the chucks normal, square on the bed, and then we'll put the other chucks on a diagonal, so it's like diamond shaped, so that I'm able to take a corner of the chucks and bring it up between their legs. Kind of, these are for my patients that are maybe more immobile and incontinent. Bring it up kind of like a diaper, because in my facility, we try not to use actual briefs because those hold moisture closer to the skin as opposed to wicking them away. And so we try to use our super absorbent chucks because those have the most wicking power. But yeah, if you kind of pull it up between their legs, kind of like a loincloth, then that's going to provide extra protection against that liquid or stool kind of like heading south into your clean bed sheet territory. So that's my most important placement issue, is making sure I know where my chucks is. And if you got to replace it, you got to replace it. It's not going to help you if it's not in the right spot. That's my soapbox.
Exactly. It's like the chucks doesn't do you any good, or the pad or whatever it is that you're using. It doesn't do you any good when it's, like you said, up past the pelvis, up towards the shoulders. Like you said, when you place it low. The top of the pad should be just above the pelvis.
And, if you have a patient that's larger, you might need to use a few extra chucks. I've seen patients before, I worked on the neuro unit for a long time, so we would sometimes have patients that weren't aware of what they were doing and, would make a mess or moved around a lot and were stooling frequently. Well, you don't want to come back to find that your patient has recontaminated everything. So we need to make sure that we're covering all the appropriate areas. So if you have a patient that's at high risk of finger painting, I've seen patients that have chucks across their whole bed because, we're doing constant cleanup. We've had patients that don't really realize what they're doing, and so you might need to check that patient more often to make sure that if they've stooled that they're not kind of playing in it, so to speak. And that reminds me, this is another tip that I didn't think of until this very moment. If you do have a patient that has gotten their hands into it, of course you wash their hands with soap and water, use a washcloth, if, whatever you need to do. What I've done before, if it's in their nail beds or in their cuticles, I've taken a little, like an emesis basin, those little like kidney bean shaped ones that are really not good for much of anything. They're great for soaking fingernails. So you can put some warm soapy water in there, maybe put a little mouthwash in there as long as they don't have any finger wounds, and then just kind of soak their fingers for a minute, and then take a soft toothbrush or a soft Q-tip and just go around those nail beds and around the cuticles and get those hands clean. No one of their right mind wants to have poopy hands, so protect your patient's dignity and their cleanliness by making sure you're getting their fingers clean too, if that, because that's the reality of it. I know that's gross, and some people that maybe haven't had to deal with this before might be a little horrified at the thought, but I've, like I said, I've had to wipe people's faces off because they didn't realize it was on their hand, and then they touched their face. So you really be compassionate, clean them up well, even if you're grossed out, even if it seems kind of extreme. Make sure you're doing everything you can to get them nice and shiny clean. Chuck's, like I've said, I've kind of gone on my soapboxes here, but Chuck's placement is key. We also want to make sure that we're positioning our patient appropriately. And so 2 things I want to talk about here. I want to talk about a technique that on my unit, we call it the pillow taco. And if I say to one of my nursing assistants that I've worked with a long time, like, hey, let's taco this guy, which I don't say it like that in front of the patient, but I'll say like, hey, when we go in and position him, I want to do a taco. They usually know what I mean. So basically what I'll do is this. So sometimes I have patients that are very likely to, when you turn them, you tuck pillows under one side of them to get them off their tailbone, but they end up wiggling around and scooting back down or scooting off the pillows. Well, this can be a problem if your patient is stooling a lot because, they end up, and I'm talking about patients that are mostly immobile, maybe are not directable, and then are incontinent on top of that. So you want to make sure they're not scooting around, scooting all over the bed, getting a small mess maybe into a bigger mess. And so what we'll do is we will essentially position them so that they have kind of a soft pillow or a turning wedge or whatever you use in your facility on both sides. Usually we just tuck a pillow under maybe the shoulder and the hip on one side of the bed. Well, what I do is I will turn them like normal, but then I will have someone help me place another pillow on the opposite side. So essentially what I'm doing is, if you think about the draw sheet and the pillows underneath it, it's kind of making the draw sheet into a taco shape, and they're kind of wedged in by these pillows. So they're not restrained by them, but it's harder for them to kind of wiggle off of the pillows, thereby wiggling around in their incontinence. Is this making any sense at all? I don't know if this is going to be a visual.
Yeah, that is something that I think that's going to be a takeaway that I use in the future too.
Another thing, if you really need to really contain, if you need to take it a step further, I've also done where you'll have someone help you lift their legs a bit so that you can put a pillow kind of behind their, under their knee, but so that you're not contaminating the pillow every time they stool, you kind of make sure the chucks is between the pillow and their bottom. And I kind of tuck it in there pretty good so that they're not as able to like scoot down as far in the bed, because I've had patients that they wiggle and squirm all over that bed, and so then they're kind of tucked in on three sides, but they're not restrained, because that would be illegal to restrain a patient without a doctor's order and the appropriate methods, as outlined by your hospital's policy. I gotta put that disclaimer on there. But when you've got the pillow taco on both sides of them, and then you've kind of got one tucked up high underneath their legs, which also elevates their heels and their knees off the ground, off the bed, so you're protecting their pressure points. But the key is to make sure that the chucks is like over the top of the pillow so that you have a barrier. And that also is going to stop it from running south towards their ankles, because you've got one extra kind of uphill climb that the poop hopefully is not copious enough to make it over the top of that. So, you kind of get them tucked in, and then sometimes they also sleep better because then they're like all cozied up like a little baby in a bed. So, I've seen that work, kind of help contain it by making it a valley. You've got like mountain range of pillows on all sides. I've used that many times. I don't know if that's applicable in all circumstances, but do what you will with that.
Yeah, that's a great idea. So we've covered a lot of territory here. And what I'm hoping is that if you're still listening at this point, that there was some pearl along the way that will help you in your stool cleaning, that will yield better results and save you time.
I know that I've learned a few things that I'm going to take with me as I move forward in my poop cleaning journey, because it's inevitable. Shit happens. Isn't that the phrase, shit happens?
It certainly does.
And it will continue to happen, especially as we see patients that are sicker in this country and they need more care. And the moral of the story for me, and my parting thought, is that always make sure that as we're doing these things, as much as we joke and we laugh, because we must, as caretakers, we must have some humor about it, we also want to protect our patient's dignity. So make sure that as you're doing these things that you're not laughing at your patient, you're reassuring them, you're protecting their privacy by, closing the curtain, closing the door, asking family members to step out, if the patient is not comfortable asking them, or having the family at the bedside. Protect their dignity. And with that goes with cleaning up the room after you've cleaned them up. So nobody wants to sleep smelling their own stool. So if there's a wastebasket by the bedside, please take that out. It is not beneath a nurse. It is protecting the cleanliness. Even our great mother of nursing, Florence, I almost said Florence Henderson, not Florence Henderson, as great as she was.
You know what?
Florence Nightingale.
I think that there's a large nursing population out there that wouldn't even know who Florence Henderson is.
I know. Mrs. Brady, for all those that are not in the know. But no, Florence Nightingale, she herself knew that it was important to keep a clean space. So empty that trash can. If you can't empty the trash can, or if it's a brand new bag or whatever, throw a Chucks over the top of the trash can to at least stifle the smell. I think that no one wants to be in a room that smells like their own doo-doo. So protect dignity, protect privacy, every opportunity that you have.
3 takeaways that I have from this show that you brought up that I have never thought of before was, the first one is the hammock for Mr. Johnson and the big twins to keep him out of the river of stool. The diamond technique with the Chucks for containment purposes, that's awesome. And I am probably going to use the taco technique the next time I have somebody that's at high risk for stooling and is squirming all over the place. So those 3 techniques are things that I am going to use in the future.
I'm so glad. I know that you've been a nurse for longer than I have, and I just want to illustrate to people that we can learn in all directions. People with all levels of experience have had all different, you've seen all different things. And a lot of these techniques I picked up from nurses that I've worked with or other nursing assistants that I've worked with over the years. And so I'm glad you were able to pick something up new. I hope other people listening can do the same, because I believe in the collective knowledge of nursing. We need to be like teaching each other the tricks to make each other's lives easier, because goodness knows there is enough working against us to make things harder. So, we got to save ourselves and our patients every bit of inconvenience and discomfort as we possibly can. So I'm glad you learned a little something today. I'm going to take the shaving cream technique, because that's something that I haven't seen done, but I have often come across those patients where it seems like no matter how many soap and water wash rags you use, you're just not getting all of it off their skin. So I like to keep a polished booty, and I hope everyone listening will walk away with a little bit more encouragement. You don't feel quite so lost walking into those poopy situations, and maybe you can even up your game and pass those techniques on to other people as well. So I want to thank you again for joining me. This has been awesome. I hope you'll come back and we can talk about maybe something less shitty in the future.
Absolutely. I always enjoy being on your podcast. So, yes, maybe we could take on a different topic, as it were.
Excellent. Well, I also, sometimes people have dropped off by this point as we're saying our goodbyes, but I just want to let people know that the podcast now has a merch shop. So I have a few things in the Etsy shop, some stickers, buttons. So if you want to support Nursing Uncensored, you can check out that shop at etsy.com/shops/nursing uncensored. And that's all. That's my plug. So thank you for listening, and happy nursing, everyone. Here at Nursing Uncensored, we may be, uncensored, but we're not unfiltered. Protected health information has been changed and concealed to comply with HIPAA. The things we talk about are from years of experience with thousands of patients, things we've read, stories we've heard. If you think we're talking about you, we're not. Also, we're real nurses here to provide helpful and accurate information. But don't take anything we say as fact without doing your own research. Refer to your state's Board of Nursing, Practice Acts, and your institution's policies and procedures if you have questions about your practice. Lastly, our very strong opinions are ours alone and do not reflect those of our employers, educational, or professional institutions. Thanks for listening, and happy nursing, folks.